Good morning. I have no conflicts of interest to declare. It's truly a matter of honor, a distinguished privilege, and a high point in my career that I stand in front of you with great humility in accepting this prestigious award. I am the sixth successor to Henry Janeway in the Department of Head and Neck Surgery at Memorial Sloan Kettering Cancer Center. I particularly want to thank Drew Ridge, our current president, at this momentous occasion, the Centennial Conference of the Radium Society. I will have more to say about the quote below his name, "We show pictures, they show curves." That was the title of his presidential address during his year of presidency of the American Head and Neck Society. Quite a pungent remark for surgeons, but a bold challenge that he took on to remind the surgeons that showing a horrendous operative slides on the screen to the audience was not what is required to shift paradigms. It is hard data done through real work that counts, and I think I will expand upon that as we go along. Today, Dr. Ridge joins a group of distinguished head and neck surgeons and oncologists who were the presidents of this society. Starting from Hayes Martin in 1942, Bill McComb, head and neck surgeon, Gilbert Fletcher, probably the most prominent radiation oncologist of the past century in the United States, Dick Jesse, Alfred Ketchum, Simon Kramer from this city, another giant in radiation oncology, Elliot Strong, Bob Byers, and Randy Weber, three prominent head and neck surgeons, and Drew Ridge. So these were the head and neck men, if I may use the word, in the past century who led this organization. Coming to Henry Janeway, there was an outstanding recitation yesterday that you heard, but I'll recap. He was born in 1873, went to medical school in New York, and upon completion of his internship, returned to New Jersey in the practice of medicine, which he did for 6 years, only to be disenchanted from private practice since his interests were more in investigative research, and he returned to New York in 1906 at the Roosevelt Hospital, working with Nathan Green, a thoracic surgeon, whereupon the two of them made numerous discoveries in surgery, particularly of the esophagus and head and neck tumors. There was a bit of personal tragedy in his life, which got him interested in radium. And because of his interest in radium and clinical research, Dr. James Ewing, the then director of the Memorial Hospital, brought him to Memorial Hospital in 1914 to be the chief of surgical oncology and lead the newly established first subspecialty service of head and neck surgery in 1914. Unfortunately, Dr. Janeway passed away due to a personal tragedy in 1921. I'm told we were going to have a couple of members of the Janeway family today in the audience. Are they here? Adelaide and David? Here they are. So I do want to recognize you. If you would rise, Adelaide Suraki and David Suraki. They are Dr. Janeway had a brother by the name of Lucius Janeway, and Adelaide is Lucius's granddaughter, if I'm correct, and David is her son. And they were very gracious to be here this morning, and I appreciate your presence today. Soon after graduation from medical school, Dr. Janeway developed an ameloblastoma of his maxilla, requiring a series of painful disfiguring operations. And you can see the sequence from the left to right in these three photographs. This is prior to the diagnosis of his tumor. This is soon upon his first or second operation, and this is after several series of operations showing the deformity on the left side of the face. These were painful, disfiguring operations, and the pain and dissatisfaction with surgical treatment generated his interest in radium. His research also expanded with Nathan Green for esophageal surgery, and along the way he developed the famous Janeway gastrostomy. His interest in radium and cancer treatment was expanded to development of radon seeds by decade emanation of ionizing radiation encapsulated in glass tubelets for interstitial implantation, so-called radon seeds in those days. As I said, he was brought to Memorial Hospital by Dr. Ewing as Chief of Surgical Oncology and Radium Therapy. And due to his interest in research and on the use of radium in the endocervical treatment of cancer of the cervix and radium plaque application for oral cancer, several other physicians got interested in radium therapy. And this was the beginning of the thought process behind establishment of Radium Society. In June of 1916, during the annual meeting of the American Medical Association, physicians interested in the use of radium met. This was, I believe, in Detroit to discuss the establishment of the American Radium Society. And it was October 26, 1916, in this very city where we are sitting, American Radium Society was founded by 19 inaugural members at the Rittenhouse Hotel, indicated on an aerial view in this general location at the Rittenhouse Square, where a current Rittenhouse Hotel does exist, although the building has undergone many renovations, and the original building clearly looked nowhere like this, but this is how the Rittenhouse Hotel looks today. So the genesis of the Radium Society was indeed in this city. The Janeway lecture was established some 13 years following the demise of Dr. Janeway in 1933, and the first lecture was delivered by Dr. James Ewing. The medal was, however, not cast until 1937, and the Janeway lecture or the Janeway medal was not awarded during the World War years 43, 44, and 45, and in the past there have been 80 previous Janeway lecturers. We heard the heraldry of the medal yesterday following the Norse mythology, so I will not repeat that, but you will recall the impregnation of Mimir and Odin on the front of the medal, and his ravens on the back of the medal. Janeway lecture had head and neck cancer as its topic several times during the course of the past century. Douglas Quick, for the first time, spoke on cancer of the larynx at this meeting, and then Arthur Purdy Stout, Bill McComb, Cliff Ash, Virginia Franz, Elliot Strong, and Maurice Tubiana sequentially spoke on one or other topics pertaining to head and neck cancer. It is only pertinent that head and neck cancer has played and continue to play importance in this society. The founder of the society, on whose name the society was founded and the medal was created, was a head and neck surgeon. Your current president is a head and neck surgeon, and number of your past presidents were head and neck surgeons. Amongst the past Janeway lecturers, these 7 gentlemen were also related to head and neck cancer in one or other way. James Ewing in pathology, Douglas Quick, Bill McComb, both head and neck surgeons, Ollie Beers from Mayo Clinic, Elliot Strong, and Alf Ketchum were all head and neck surgeons who were previous Janeway lecturers, and so was Gil Fletcher, the radiation oncologist par excellence of the past century, who gave the Janeway lecture. The association thus between the American Radium Society, Henry Janeway, head and neck surgery, and Memorial Hospital has a 100-year history also. The Head and Neck Service at Memorial Hospital, started by Henry Janeway in 1914, celebrated its own centennial 2 years ago in New York during the 5th World Congress of the International Federation. And the theme of that Congress was a century of progress in head and neck cancer. And I chose that topic to deliver today's Janeway lecture. Needless to say, Henry Janeway is prominently displayed on the cover of this book we put together of the most prominent contributions and contributors of the past century in head and neck surgery, who were leading physicians in many specialties. So to put the entire progress in the specialty of head and neck cancer in one concise compendium was literally an impossible task. So how do we, or what equitable democratic process can we use to cull out the most important contributions which set paradigms in the practice of head and neck cancer treatment as we do today? So we selected the specialty into 19 topics, invited 47 contributors to submit 20 published papers in their opinion on 2 topics amongst these 19, which came with 2,100 articles to review. We had an editorial committee of 8, which pared down the 2,100 articles to 200, and then the 3 editors picked 1 out of 2 amongst the 200 articles to 100 most prominent contributions. Then we invited current leaders in this field to add a commentary to these articles and put this book together. Needless to say, to summarize the great strides and progress made in the past century in head and neck cancer, in the remaining 45 minutes for me would be clearly an impossible task. But I will share with you some important highlights that have impacted upon how we practice head and neck surgery and oncology today. So let's start off with biology, epidemiology, and risk factors. When you talk of those topics, Denley Slaughter's name comes to the name as the first to conceive the concept of field cancerization. By review of over 700, nearly 800 oral cancers of the oral cavity, lip, and pharynx, he came to the conclusion and appreciated the concept of field cancerization of oral cancers even before the carcinogens such as alcohol and tobacco were identified. His concepts still stand true today. The first prospective study on the role of alcohol and tobacco in multiple primary cancers of the upper aerodigestive system was conducted by David Schartenfeld, the then chief of biostatistics at Memorial Hospital, and Ernie Winder from the American Cancer Society. Some of you might remember him. On that study of over 700 patients with head and neck squamous carcinoma, they showed an incidence of 7.3% second primary tumors within 6 years. And here came the concept of prevention of second primary by cessation and change of lifestyle. A similar study of over 50,000 villagers was conducted in India by Gupta and Mehta on incidence rates of oral cancer in premalignant lesions in a 10-year longitudinal follow-up. And they showed that the rate of transformation of leukoplakia to cancer was 7% over a 10-year period, coming to approximately 1% per year of follow-up. And here came the concept of prevention of oral cancer, either by surveillance, observation, intervention, chemoprevention, or simple guidance and counseling. So the concepts that we practice today were thought of by these individuals by these remarkable groundbreaking studies. Sir Richard Doll and Richard Peto showed us the causes of cancer and demonstrated quantitative estimates of avoidable risks of cancer in the United States. And their epidemiological study estimated reduction in cancer deaths by avoidance of modifiable risk factors. And our concept of counseling the patients to quit smoking and drinking for prevention of a second cancer comes from the observations of this study. Staging of head and neck cancer. How can we talk about staging without remembering Pierre Denva, who first introduced the concept of tumor nodes and metastasis, anatomic factors of importance in staging any human cancer. The American Joint Committee on Cancer Staging and the UICC quickly adopted the TNM system, and which remains today in vogue, although there are other non-anatomic factors being seriously considered. J. Piccirillo in 1995 published on adding comorbidity to improve prognostication over TNM staging alone. And he was a visionary because we have come to realize that comorbid factors such as Karnofsky status, such as lifestyle, such as anemia, such as response to therapy, will all come into the fore in future editions of staging systems. Patty Groom from Toronto compared and published head and neck stage groupings in cancers of the oral cavity, comparing 7 different staging systems, and suggested that TNM staging could be improved by using empirically derived schemes. And she postulated that in order for a staging system to be valid and useful, it should have hazard consistency, hazard discrimination, outcome prediction, and balanced distribution. The fundamental hallmarks in creating a viable staging system. In the area of paranasal sinuses, skull base, and paragangliomas, some individuals stand out. Our former president, Alf Ketchum, and a former Janeway lecturer, was amongst the first to break ground in approaching tumors of the ethmoid which approach the skull base. When he was at the National Cancer Institute as chairman of the surgery branch, he embarked upon operative procedures developed with his neurosurgery colleague, Van Buren, a craniofacial approach by employing craniotomy first to assess the extent of the tumor, and paved the way for innovative strategies to treat tumors involving the skull base. But for his demonstration of the safety and efficacy of this approach, the entire specialty of skull base surgery today would not exist. My former colleague, John Lewis at Memorial Hospital, must be credited to be the maverick in approaching the lateral skull base. He developed innovative techniques for temporal bone resection, as was mentioned yesterday by Snell, or I should say on Saturday by Snell Patel. He did not have high-speed drills. He did not have neuronavigation. He did not have CT scans or MRI to assess the extent of the tumor. He developed the technique of temporal bone resection with a mallet and osteotomes. Barbara, that implies basically a hammer and a chisel. But his report of his first 100 cases of temporal bone resection doubled the cure rate compared to radiation therapy alone, published by Manuel Lederman from London, reporting 14% survival for auditory canal cancer treated by radiation. So his largest series of temporal bone resection with reduced mortality in improved cure rates today stand amongst the most important publications in lateral skull base surgery. Building upon his experience, Hugo Fisch from Switzerland pioneered lateral skull base surgical approaches for paragangliomas, the glomus jugulare tumors, and tumors of the auditory canal and nasopharynx. There was a paucity of viable literature on outcomes of skull base surgery because all the published reports until the mid-1990s were single institutional reports of small series of patients of varying histologies and varying stages. So we put together a collaborative database of over 1,500 patients treated in 17 centers across the world, and my colleague Snehal Patel did the data analysis, and we established benchmark outcomes by histology, by bone, by dural invasion and brain invasion, and orbital involvement. The data that was shown by Dennis Krauss on Saturday in the head and neck outcomes. But this database or data is still being used to compare any outcomes data on skull-base surgery by any means of treatment, because this large data set otherwise does not exist. William Shamblin established a classification of carotid body tumors to facilitate the safety of surgery and to define the indications and or contraindications of hazardous and even morbid or mortal surgery, if I may use the word. And Shamblin's classification of carotid body tumors remains today the gold standard in managing patients with carotid body tumors. Shamblin type 1, type 2, and type 3, head and neck surgeons in the audience will appreciate that Shamblin type 3 is a nightmare for the surgeon in the operating room. Yes, it can be done with proper technical expertise, but it is not a operative procedure to be embarked upon by a rookie. Observations on the other side from Leiden University in Belgium took us to the other side, that normal life expectancy could be expected by simply not intervening or treating these patients with paragangliomas. A 50-year cohort study of paraganglioma families concluded that observation, rather than disabling surgery causing cranial nerve deficit, offers equal long-term survival and a better quality of life. And thus today, there is a major paradigm shift in the management of patients with paragangliomas in the neck, particularly near the skull base. And in my first 10 years of practice, nearly 90% of patients with paraganglioma got operated. In the past 15 years, I would say more than 90% of the patients are being observed. They come and see me once a year, get their imaging study, and they go home. They remain asymptomatic. A major paradigm shift. In skin cancer and melanoma, Frederick Mohs, as early as 1948, showed that skin cancers can be treated by simple means, but getting effective margin control through his chemosurgery technique based on over 800 patients. His technique subsequently got called as Mohs micrographic surgery of sequential tangential resection of tumor, obtaining surgical margins as you go along and sparing normal tissue. This is a standard of care and practice today relevant to dermatologic practice, particularly in basal cell carcinomas, but also employed in selected patients with squamous carcinoma and other skin cancers. Helmut Gepfert, the former chief of the head and neck service at MD Anderson, brought to our attention perineural invasion of major nerve trunks in the head and neck area and identified the risk of nodal metastasis, distant metastasis, and decreased survival related to perineural invasion, and the importance of PNI in management of patients with skin cancer of the head and neck. And we cannot forget the landmark contribution of Alexander Breslow, who for the first time showed that tumor thickness of cutaneous melanoma, measured thickness, was more important than histologic depth of invasion, which came out of this city by Clark from Temple, which showed Clark's leveling pertaining to the layers of the skin, but that was less predictable of outcome than the measured thickness. And today, Breslow thickness remains not only the standard of assessment of the extent of tumor and prognosis, but is entered into the staging system for melanoma. In nasopharynx and oropharynx, Ann Lee, the protege of John Ho in Hong Kong, probably did one of the largest retrospective study of over 5,000 patients of nasopharyngeal carcinoma treated between 1976 and 1985, and set the standards for continuing improvement in the treatment and outcomes of nasopharyngeal cancer, and today continues to contribute to the growth in prognosis, staging, treatment planning, and outcomes reporting for nasopharyngeal carcinoma. Parallel with that, observations from the Veterans General Hospital in Taiwan reported quantification of plasma EB virus DNA in patients with advanced nasopharyngeal carcinoma. This was brought up yesterday in one of the presentations, that today EBV DNA is a valuable marker in following the activity of nasopharyngeal carcinoma post-therapy for recurrent tumor before the tumor became clinically manifest either on the surface or as a recurrent metastatic tumor. So EBV DNA is clearly valuable for monitoring response to therapy in nasopharyngeal cancer. Recently, in the past 20 years, we have to credit Maura Gillison from Hopkins, who, upon her review of over 250 patients with head and neck carcinoma, noted that HPV-positive tumors had a 59% reduction in the risk of death from cancer compared to HPV-negative cancers, a breakthrough observation. That was supported by a follow-up study from the same institution led by Carol Fakhri. This was a survival trial of HPV-positive patients in a clinical trial comparing response to induction chemotherapy with the outcomes of 82% for HPV-positive versus 55%, reflecting into comparable 2-year survival rates, and reported that HPV was strongly associated with response to treatment and survival. I will have a little bit more to say about the HPV conundrum in the next few minutes. Kian Ang, our dear friend, and I miss him, he was my personal friend, and he would have been sitting in the front row at this meeting had he been with us. He, reviewing the RTOG 0129 data, tried to stratify risk groups in the HPV-positive patients and defined low-risk, intermediate risk, and high-risk groups based on HPV status, smoking, T-stage, and nodal stage. His risk stratification system has now allowed us to develop clinical trials to de-intensify treatment in the low-risk patients and intensify treatment in the high-risk patients if we are going to see improved outcomes and reduced morbidity in oropharyngeal carcinoma. In neck metastasis, George Cryle, at the turn of the past century, past meaning the 19th century, in 1906 reported on his personal experience of 132 neck operations and established radical neck dissection as the standard of surgical care of neck metastasis. His operation was complete, comprehensive, effective in controlling cancer, and easily reproducible. This article was reproduced in 1987 for those who could not get the original from 1906. My former mentor and the past president and past Janeway lecturer, Hayes Martin, has many accolades and contributions to talk about, and one slide would not be sufficient. But I've tried to truncate 2 of his most important contributions to head and neck cancer. And one was the first report on fine needle aspiration biopsy for establishing tissue diagnosis of cancer from masses and lumps in the neck and elsewhere in the body. And FNAC, or FNAB, as you would like to call, became the standard of care for the past 85 years. He also introduced aggressive surgical management of head and neck cancer and ushered in the era of radical surgery, and it is rightfully called the father of head and neck surgery during the past century. Jonas Johnson from Pittsburgh reported for the first time in 1981 the importance of extranodal extension of metastatic carcinoma and its impact on outcome. Today, E&E or ECS is an important parameter on which we base treatment planning and report outcomes. We did a large study of over 1,100 radical neck dissections to study the patterns of neck metastasis, and reported in 1990 that metastatic spread from cancers of the upper aerodigestive tract was sequential and predictable. Skip metastases were rare, and metastatic disease in the clinically negative neck to level 5 was almost non-existent. And these data provided support to the use of selective neck dissections to avoid morbidity of the classical radical neck dissection. And that ushered in the area of the supraomohyoid neck dissection, the selective jugular node dissection in an elective setting. In reconstructive surgery, Varham Bakamjian from Roswell Park in Buffalo introduced the concept of medially basing the deltopectoral flap, initially described by Zovikian in 1920, and used the flap in total reconstruction of the pharynx, tubed the flap and connected it to the base of the tongue and esophagus, and put the continuity of the alimentary tract together in 2 operations. Deltopectoral flap became the workhorse for immediate reconstruction of the pharynx in the 1960s and 1970s until his countryman, Steve Arian, first described the pectoralis myocutaneous flap in 1978, demonstrated the surgical technique of elevating the flap, described the anatomy of the vascularity to the flap, and the pectoralis major myocutaneous flap became the workhorse for immediate reconstruction in the head and neck in the 1980s. Along the way, however, microsurgery was developing. And microsurgery was developing since the 1960s, initially employed in trauma for replantation of digits and arms, but eventually brought into the arena of reconstructive surgery. And David Suter from Glasgow described in the English literature for the first time the radial forearm free flap, which was described prior to that in the Chinese literature by the Chinese folks. But it never crossed the hemisphere and came to the Western world until Suter's publication of use of the radial forearm free flap in reconstruction of surface defects in the oral cavity. David Hidalgo, my former colleague from New York, takes credit for setting the standard of mandible reconstruction as a one-stage operation. He conceived, devised, and popularized the fibula-free flap for immediate reconstruction of the mandible. Prior to that, we were totally disappointed, disgusted, and frankly unhappy with the methods of mandible reconstruction we had it available. His discovery and introduction of fibula-free flap today remains the standard of care in immediate reconstruction of the mandible, and I will share a picture, Drew, with your permission, to show the audience. Fu Chan Wei, perhaps the largest trainer, or I should say trainer of the largest number of microsurgeons in the world from Taipei, described the anterolateral thigh flap. I have visited his department. They have 8 free flaps every day of the week, 7 days a week. They have a recovery room for free flaps where anywhere from 10 to 12 patients are recovering every day. He trains 14 microsurgery fellows every year. And I believe he has trained not hundreds, perhaps thousands of microsurgeons around the world. His anterolateral thigh flap is a multifaceted flap to reconstruct a variety of defects in the head and neck. And those of you who are surgeons in the audience would appreciate the importance and the need for pliable and facile tissue to reconstruct surgical defects. In the arena of thyroid, parathyroids, and salivary glands, George Kreil Jr., the son of George Kreil of neck dissection, first introduced the influence of age on outcomes in thyroid cancer, and thus came the cutoff of 45 years age distribution in the staging of thyroid carcinoma. Observing the varying prognosis in children versus adults with papillary carcinoma, he first reported in 1953 the relationship of age of the patient to the natural history and prognosis of cancer of the thyroid gland. George Irwin from Miami introduced intraoperative monitoring of PTH by immunoradiometric assay to assure the completeness of parathyroidectomy in patients undergoing surgery for primary hyperparathyroidism, and converted the paradigm of 4-gland exploration to single-gland excision done with a small incision almost as an outpatient procedure by intraoperative monitoring of quick PTH, which could be obtained within 15 to 20 minutes. Ashok Shah and the rest of the group at Memorial demonstrated on the Memorial's large database on thyroid cancer the importance of risk group stratification in selection of treatment and in outcomes reporting. This strategy of risk group stratification is now adopted by the American Thyroid Association as well as the AJCC in developing staging and guidelines for treatment of thyroid cancer. Martin Schlumberger's group from the Institut Gustave Roussy in France was the first to bring to our attention in a publication by Carol Rubino the risk of a second primary cancer in patients receiving radioactive iodine therapy. The risk increased and reached up to 27% second primary in patients receiving radioactive iodine. Needless to say, with increasing doses, the risk increased. And the risk of second primary being leukemia, soft tissue sarcomas, bone tumors, colorectal cancer, and salivary gland tumors. And thus came the concept of identifying patients who are truly in need for radioactive iodine and not employ willy-nilly radioiodine ablation and or therapy on every patient with thyroid cancer. Today, I would say a great majority of patients, over 85% in major university centers, do not get radioactive iodine after thyroidectomy. It's only select 15 to 20% who are truly in need of radioiodine get the radioiodine treatment. Ron Spiro, my former colleague, published a series of papers on salivary gland tumors, and his papers remain today the important publications providing benchmark data on outcomes from surgical treatment of salivary tumors, the experience gleaned from over nearly 3,000 patients. Ian McGregor from Glasgow again, from Scotland, showed us the method by which oral cancer invades the mandible and demonstrated on whole organ section studies that extension of oral cancer to mandible did not occur by direct infiltration through the lingual cortex, but the tumor progressed up to the alveolar margin and through the dental sockets into the cancerous part of the bone. And his findings allowed conservative management of the mandible in oral cancer, such as marginal mandibulectomy. In radiation oncology, and to this crowd, what I'm going to say would be a minuscule of information and progress over the past century. But I felt like singling out a couple of individuals whose contributions are legion. Gil Fletcher, former president of Radium Society and Janeway lecturer, for the first time drew our attention to the importance of precise data recording and reporting of treatment planning, dose reporting, and outcomes of radiation therapy in his series of supraglottic laryngeal carcinomas. Dr. Fletcher had many, many contributions to his credit, and my presentation simply would not do justice to his outstanding career and contributions to the field of radiation oncology in the past century in the US. Karen Fu was the PI on the RTOG phase 3 trial, randomized to compare hyperfractionation and two variants of accelerated fractionation to standard fractionation. and concluded that hyperfractionation and accelerated fractionation with concomitant burst had better locoregional control, although the survivorship did not seem to be affected. In combined modalities and organ preservation strategies, we have made major progress. The famous VA trial combined chemotherapy with radiation and for the first time introduced the concept of organ preservation. Greg Wolf, the former chairman of otolaryngology at University of Michigan, was at the NCI when this trial was initiated in the 1980s. And the concept of the trial was very simple. I won't belabor, but it showed that in patients on trial with induction chemotherapy and radiation therapy, 64% of the patients could preserve their larynx compared to those who had undergone laryngectomy, although the survival was comparable at 68%. But this study gave very important other information. We came to know that chemosensitive tumors were radiosensitive tumors, an important observation which led to the genesis of the concept of organ preservation. The same concept was employed by Jean-Louis Lefebvre in France to preserve larynx in hypopharyngeal carcinoma, although it did not show as good a success as it did in larynx. And functional larynx preservation in the hypopharynx at 5 years was only in 35% of the patients who had shown complete response to induction chemotherapy. Al Saraf from Detroit, Michigan, introduced the concept of chemoradiotherapy in the treatment of nasopharyngeal carcinoma. This was brought up yesterday, and today it remains the standard of care in the treatment of advanced nasopharyngeal carcinoma. Jean-Pierre Pignon needs to get the credit for putting the truth on the table. He did a meta-analysis of 63 clinical trials of over 10,000 patients employing chemotherapy in head and neck cancer, and showed that there was only absolute survival benefit of 4%. So the gear shifted, that the role of chemotherapy was not geared in prolonging or improving survivorship, but improving the quality of life of the patients. Arlene Forestier, again from Hopkins, led the RTOG 9111 trial, showing that concurrent chemoradiotherapy was preferable to induction chemotherapy to radiation therapy alone, and it remains today the standard of care. And Barbara Burtness established the role of targeted anti-EGFR agent cetuximab in the treatment of head and neck cancer, and through a randomized trial of ECOG on 117 patients. Marshall Posner from Mount Sinai, now in New York, showed improved locoregional control rate using induction chemotherapy with 3 drugs, adding Taxotere to platinum and 5-FU, being superior to the 2-drug doublet regimen. And Jan Vermorken from Antwerp showed improvement in overall median survival, although modest, from 7 months to 10 months, with the use of cetuximab in a randomized trial in untreated patients, unresectable patients, or with recurrent or metastatic carcinomas of the head and neck. And therein came introduction of cetuximab in the arena of systemic therapy of patients who are not able to tolerate or not candidates for cisplatinum. In patients undergoing laryngectomy, the revolution brought about by Mark Singer and Eric Blom has stood the test of time. Tracheoesophageal puncture, literally immediately after laryngectomy, and introduction of a valve prosthesis has become the standard of care for voice rehabilitation after laryngectomy. They need to be commended for this simple but innovative means of restoring voice. Too numerous publications in basic research for me to conclude or include in this presentation. So I have not gone back many years into this because it will need a whole 1-hour presentation. But I've taken some more recent work of our leading researchers of the past 2 decades, and there comes in the work from Joe Califano from Hopkins, who provided a framework for our current understanding of the tumor progression model of genetic abnormalities at each stage of tumor progression of squamous carcinoma, from epithelial dysplasia to invasive carcinoma. And his work remains the fundamental basis of identifying genetic manipulators at each stage of tumor progression, which may come into force in the years to come as therapeutic agents. Jennifer Grandis from Pittsburgh, in her studies, showed expression level of EGFR and TGF-alpha being the strongest predictors of disease-specific and cause-specific survival, disease-free and cause-specific survival, and paved the way for targeted therapy for TKIs and cetuximab. Nishant Agarwal, initially from Hopkins and now at Northwestern in Chicago, did whole exome sequencing of 32 tumors at Hopkins and showed Notch1 mutations function as tumor suppressor genes. His current work is work in progress, and I expect much to come from him because his entire hypothesis on whole exome sequences lies in parallel with what we heard yesterday from Mark Robson on whole genome sequencing of tumors and normal tissues to call out the bad actors and see what we can do with that. In quality of life, there are 2 individuals who stand out. Ernie Weimiller from Seattle had a lifelong interest in quality of life studies, and it was his work that led to the development of University of Washington quality of life study, which we employ regularly in our QOL reporting studies. And Randall Morton from New Zealand showed that the same instrument cannot be employed throughout the world. There are cultural differences in patient-reported quality of life data. And he compared outcomes of treatment between Toronto and Auckland, New Zealand, and showed that truly there are cultural differences in quality and quantity appreciation by the treated population. So to summarize, advances in surgery have gone from ablative surgery to radical surgery to conservative function-sparing surgery. From delayed reconstruction, we have gone on to immediate reconstruction, microsurgery, free flaps, and composite tissue transfer. From radical neck dissection to selective neck dissection. From paying more attention to form and function and aesthetics. And we are now in the era of minimally invasive surgery, endoscopic surgery, robotic surgery, and God knows what more. Advances in radiation oncology are two-faceted issues in radiation sources and delivery systems. We have come from radium to superficial low voltage radiation to super voltage to photons, electrons, neutrons, protons, particle therapy, pi-meson, and on and on. And the delivery systems from application of radium plaques and radium needles to radon seeds, superficial and deep X-rays, parallel opposing ports, conformal radiation, 3D treatment planning, IMRT, VMAT, 3D, protons, IMPT, and the field keeps on changing. Advances in medical oncology similarly apply to drugs and drug delivery systems. From cytoxan to immune modulators, and from palliative chemotherapy to immunotherapy, we have seen the whole spectrum change in the past century. Advances in allied specialties have equally taken place in pathology, radiology, nuclear medicine, dental oncology, prosthetics, rehabilitation, quality of life and support services, nursing, social services, patient support groups, and most importantly, internet-based resources which the patients can have anywhere in the world. I was told by our president that the focus of this society, as it should be, is multidisciplinary care. So how have we moved into multidisciplinary care? Surgery has been the mainstay of treatment for the past 2.5 centuries in the treatment of head and neck cancer. With the identification and introduction of radium at the turn of the past century, that came into play in the therapeutic arena. Introduction of cytoxan during the Second World War, mustard gas, brought about chemotherapy. But the first concept of combining two modalities of treatment took place in 1960. And I'm proud to say, at my own institution, and my predecessor, Dr. Elliot Strong, was the PI on the first ever trial combining radiation therapy and surgery, the preoperative radiotherapy trial conducted from 1960 to 1969, which showed improved local control rate but no improvement in survival. But that observation led to the next study led by Simon Kramer, the RTOG 7303, of postoperative radiation therapy, which remains today the standard of care. The years 78 to 82 were the era of induction chemotherapy supported by the head and neck contracts program from the NCI. It was a negative study, but it showed us three things: that drug sensitivity implies better prognosis, that drug sensitivity equals radiosensitivity, and that drug sensitivity can be used to stratify patients for further therapy. And that led to the concept of larynx preservation. 85 to 89, the VA trial of induction followed by radiation. 92 to 2000, the larynx preservation approach was extended to hypopharynx cancer. And in the same time, induction chemotherapy got converted to concurrent chemoradiation. The two studies reported in 2004 by EORTC and RTOG of postoperative chemo and radiotherapy identified high-risk patients with positive margins and extranodal extension as candidates for adding chemotherapy to postoperative radiation. In the past 10 years, we have moved on to using targeted therapy with anti-EGFR agents. And we are quabbling in the oropharynx conundrum today. Do we de-intensify? Do we intensify? Do we operate? Not operate? And I think current trials will hopefully give an answer to this in the next 5 to 10 years. As was brought about by Mark Robson yesterday, we are constantly in the search for new targets and newer targeted agents. We are in the search for molecular profiling of individual tumors to deliver precision medicine. But there are, as was shown very eloquently, ethical and maybe legal issues. So, have we made progress in longevity and quality of life in the past century? And the answer is resounding yes. I'll share one example with you in oral cancer. In the 1960s, of all comers, 48% survived 5 years. That has gone on from 1960s to 57%, 68%, and so on and so forth. This was the state of the art in the 1960s after mandible resection. We had no means of reconstructing mandible. This man is alive 10 years, but he's basically a hermit because he doesn't like to go out. 2016 is a different scenario. This young girl from Israel saw me in January of past year with a sarcoma of the mandible. That's her tumor, and that's the extent of the tumor depicted on her face and her surgical specimen. But here she is, 3 weeks out, 3 months out, and 6 months out. You would be hard put to tell me which side of the face she had an operation. And that's the state of art today. So as we celebrate the centennial of the American Radium Society and a century of caring, Dr. Henry Genevieve would be proud to know that more patients are living longer with better quality of life. In closing, I want to leave you with several of the quotes of our President Drew Ridge from his various presentations. I've taken notes. Remember, he reminded the surgeon, we show pictures, they show curves, and surgeons have taken this to heart and have embarked upon clinical trials. But his words of wisdom are very clear here. Cancer care in the 20th century has moved on to be a multidisciplinary specialty. Very true, Drew. I applaud you for that. We have moved on from case demonstrations of techniques to evidence-based medicine driven by data derived from randomized trials. So true. Our ultimate goal is to identify specific targets to practice precision medicine and deliver personalized care to our patients in future. Thank you.